everyone, and welcome to today's podcast and event regarding Physicians Associates. Today's event is brought to you by the Nottinghamshire Alliance Training Hub, or NATH. We'll start with a few introductions and then we'll kick off. So by background, I'm a GP. My name is Minali, and I work in Hyson Green, primarily as a GP there. I'm also an educator and associate for the Nottinghamshire Alliance Training Hub. And my co-presenters today are Simran, who is a PA, and Saira, who is a GP. I'll hand over to Simran first.
Hi, my name's Simran and I'm the Physician Associate Ambassador for Nottingham. I also work for the Nottingham Alliance Training Hub, NATH, and I have been working in GP now for 3 years. But before I introduce the rest of what I do, I'll pass over to Saira.
Thank you very much, both of you. Yes, I'm Saira Jawaid, one of the GPs as well by background, and working for Nottinghamshire Alliance Training Hub now for about 4 years, and supporting multi-professional support unit. And I'm very excited to listen to Simran today. So, do you want to go ahead, Simran, and talk a little bit more about your background?
Yeah, so like I said, my name's Simran. I am a Physician Associate Ambassador for Nottingham Alliance Training Hub, but I'm also a Physician Associate working across Nottingham, across multiple PCNs. So a little bit about myself is that I have been qualified now for 3 years, and I've worked primarily in primary care in GP practices, and I've just sort of been working most recently in Bestwood and Sherwood. I have been trained in frailty, and this is an area of medicine that I absolutely love. And off of the back of that, I have been doing quite a bit of care home work, ward rounds, and sort of independently managing these on my own with a sort of GP in the background for my PCN.
Wonderful. Thank you, Simran. And can you tell us a little bit more about why you decided to become a PA?
So for me, becoming a PA was something that I've wanted to do for a while, for a number of years. I actually used to do a degree that led me on to science, and following doing a couple of placements and a sandwich year, I sort of realised that wasn't for me. I wanted to sort of have a better understanding of illness and medicine and the impact on the human body. I had some personal experiences with my grandparents where I sort of didn't understand why they were so sick and what I could do to make things better and why they weren't getting any better. And I wanted to sort of delve into that and understand what was the reason behind them becoming so unwell. And I didn't want to go to university and sort of do medicine, which is one of the reasons I didn't want to sort of become a doctor, because with PA it's sort of not as long at uni, but you kind of can work in the same environment, and it also gives you a lot of flexibility and a better work-life balance as well. You don't have to move around the country and do placements as much as someone who's training to be a GP would, or you know, in secondary care. As a PA, you kind of do your training at uni and that's about it, which kind of quite appealed to me. So yes, I quickly realised after doing my science degree that science wasn't for me, and I wanted to go down medicine, but not the conventional medical degree and then becoming a doctor. I came across PA, which just sounded perfect for me.
Wonderful. And you've mentioned working in a variety of specialties. It sounds like you can choose to work in either primary care or secondary care. Is that right?
Yes, that was another thing that appealed to me. As a PA, you can kind of chop and change where you'd like to go. So just for example, if I was to graduate and start in GP as I have, and then tomorrow I think I want something a bit more challenging and I want to go into cardiology, I can then go into cardiology and work as a PA on the cardiology ward. And then in another 5 years, get bored of that, I can go and change on to respiratory. And you can kind of go around and do whatever you sort of want, and sort of specialize in what takes your fancy as well.
Wonderful. And if you are switching from, for example, secondary care to primary care or primary care to secondary care, do you have to do extra qualifications at that stage, or is it something that you can just progress to and do CPD accordingly?
You kind of just progress from it and do CPD, and it's sort of on yourself to go back and do all that reading. So for example, if you were in cardiology, you'd use all your cardiology knowledge. You can still apply that into the GP land, but then you'd have to go through everything. So you'd have to go through, you know, ENT, RESP, gynae and everything again, which you may well have forgotten since uni. So it's up to you to retrain yourself and go on to these courses. But like I say, a lot of things cross over. So a lot of people may go into mental health, they then come into GP, and we always have a lot of mental health anyway. So it's fantastic to have people who are from sort of specialities, if you want, come into general, because they can then actually teach other clinicians and things and use that to their advantage. So that's brilliant.
Wonderful, thank you. And in terms of skills and qualifications, you've mentioned, of course, covering a wide range of different subject areas or topic areas at university. Can you tell us a little bit more about what skills and qualifications you have, but also what is necessary for the role itself?
As a PA or somebody that's going to be a PA, you need to have an undergrad in science or healthcare degree. So that could be you know, mine personally was human biology, but there were some biomedical scientists, there were some radiologists, there were some nurses, there were some midwives, podiatrists, anything that's sort of healthcare or science related can be your undergrad degree. And then you go on to do the postgrad masters, which is the physician associate studies masters. That again, it can either be a postgrad diploma or it can be the masters. Now, the difference between the two is that the masters obviously has a dissertation with it, and you get the Masters of Science, whereas the diploma, you don't get that. And there's also a difference in the funding as well and how that works with the universities. Mine was the 2-year masters. Both degrees are 2 years. But recently, actually, there has been a course that's come out for a handful of universities that allows you to do the undergrad and masters incorporated. So I think it's between 4 to 5 years in total. Whereas I did 6 years because I did a 4-year undergrad with a sandwich year and then a 2-year masters. Normally, people would do a 3-year undergrad and a 2-year masters, so that would be 5 years. But I believe the integrated degree of the physician associate studies would be around 4 to 5 years. And everything comes into that. So you'd go straight out of school or college at 18 and you'd go straight into being doing a PA course, whereas someone like myself was a little bit later, probably around 21, 22 when I started doing it. So it's just a little delay on your qualifying and things, and it's to do with funding. So yeah, it's worth looking into. The other thing was passing. So you've done your degree, you've done your undergrad, and you've done your masters now. In order to actually work as a PA, you need to be doing the national exams. So the national exams have 2 parts to them. They have the MCQ, which is the multiple choice questions, and then you have the OSCE stations. And you've got to pass both of these elements in order to become a PA at the end. I think you get 3 tries with it as well. And that is to make it sort of the same across the board for everybody across the country. So people could say that my teaching at De Montfort Uni was different to somebody else's teaching at Leeds, say, for example. But in order for them to both be the same and everybody to be on the same level, we have a national exam, which, like I say, is 200 questions and 14 OSCE stations, which needs to be passed. You then get your PIN and registration and things.
Wonderful. And can you tell us a little bit more about what might change for the future in terms of prescribing? You've mentioned about regulation changes as well.
Yeah, so we should be getting regulated by GMC by the end of this year, which is 2024. So by December, we should be regulated by GMC. With regulation also comes prescribing rights. And obviously, I appreciate that all of PAs like myself that have already been qualified don't have the course under our belts. So we will then be sent by either yourself or your workplace. We'll send you onto a prescribing course to kind of get you up to that level. People that are then going on to PA courses, that will be incorporated into their course, so that it may be a little bit longer than the 4 or 5 years or 6 years, but then that means you come out with a qualification to be able to prescribe and be a PA, so a PA prescriber, as you would say.
Wonderful, thank you. And I've just got a few questions just to clarify. You mentioned that you did the masters, but you've got the option to become a PA by doing the diploma without the dissertation. Does a PA who has the diploma versus a PA who has the masters have the same, I guess, responsibilities and the same clinical work in practice, or is there different workload or different requirements for each one?
So as things stand, there isn't any difference between what you do when you qualify. So for example, I do have friends that did the postgrad diploma, and obviously I did the masters. We do the same kind of work. It may just be that when you progress further into your career 10, 15 years down the line, people, if it was between somebody with a diploma and a master's, they would say, right, well, you've got a master's, so it kind of holds you at that, so you shouldn't say it, but a little bit higher regard. If you want to go down management route, or you want to go down more clinical, whatever it is you want to do to progress your career, they may prefer you to have a master's because you've demonstrated that you've been able to do that dissertation that maybe somebody with a diploma hasn't. So right now, no, there's no differentiation in what we do. We all do the same. But further down the line, when we get GMC regulation, we're prescribing and everything, and you want to carve your career, it may make a slight difference.
Yeah.
But having said that, anybody that's done the diploma can at any point in their career upgrade to a master's and sort of change up to a master's, because it's just the element of a dissertation. So
Yeah.
you can just go back to uni and pay for the extra couple of modules or whatever it is to convert that into a master's.
Wonderful. So it sounds like the PA still has the flexibility to then progress their postgraduate qualification further if they wish to.
Absolutely.
Wonderful. Thank you. And also, you mentioned the national exam. Is that incorporated into the diploma or masters, or is that a separate thing that PAs have to apply for completely separately?
It is completely separate. So this is something that's completely separate, and there's no funding for it. This is something that you've got to be funding yourself. So it's self-funded, and it is very, very expensive. It's around £1,000. So it is quite expensive. So doing your uni is separate from doing the nationals, because if you don't pass uni, you can't do the nationals.
I see.
So it's sort of like a progressive thing. But without doing the nationals, you can't practice as a PA. So having the degree is useless. So it kind of works hand in hand.
I see. That's really interesting. Thank you for clarifying that. Lovely. And can you give us an example of your working day? So now that you're, say, you're fully qualified, you've done your masters and you've done your national exam as well, and you've passed it successfully, what does your working day in primary care typically look like?
So a typical working day actually varies from person to person. So as a PA, another thing that attracted me to it was the flexibility. So with especially working in general practice and not in secondary care, you can actually be the master of your day. So if you want shorter days, you can work your typical 9 to 5, but actually you'll find that a lot of PAs decide to work a 10-hour shift. So you'll work typically 8 till 6. That means that you kind of squash your week into 4 days and get your extra day off a week, which is really good for mental health. So for myself, I do 10-hour shifts because I prefer to get everything done in one day rather than coming in every day and working. In addition to this, it also depends where you work. So for example, different PAs work at different places and some work at the same place. So I've got colleagues that work in one practice 4 days a week, whereas I've been working in 3 practices or 2 practices across the week. And each place works differently. So there's no format that is the same for every PA. When I worked at one practice versus the other practice, one practice were very pro mental health, pro sort of not bogging you down with so much heavy work that they wanted to incorporate bloods into my morning, get me doing different things, whereas the other practice just preferred me to do straight up appointments. One practice preferred me to do telephone triage as well, and one didn't. Another practice wanted me to do on-call duties, another practice didn't. So it really does depend on where you work, and it's about working with your managers. And also along with that is appointment times. Typically when you're a newly qualified PA, and again it does depend on where you start and your employer, you tend to start on longer appointment times. So for example, I started on say 30 minutes, and then over time you come down to 25 to 20 to 15, and you kind of settle on 15. And that's to kind of ease you in, because obviously you're straight out of uni. And I'm at the point now where I'm on 15-minute appointments. So typically a day would be, I go in at one surgery, I go in the morning at 8 a.m. and I would knock out 6 bloods. I would have patients come in that are booked in with me, and I would just do these bloods and get them out of the way, and that sort of eases me into the day. I then have a little block where I just kind of can get myself together, put my bloods in the box and clean up and tidy up. or to catch up, because sometimes you do get elderly people that are difficult to bleed. And then I would go on to 3 same-day telephone triage appointments. Following that, I would have 3 face-to-face pre-bookables where I can either pre-book or some other clinician can pre-book with me if I want to follow somebody up or anything like that. And then I have a block to catch up. After this block, I've got a debrief. Now, debrief for PA is really, really important. It is literally the core of everything we do. Everything you do is followed by a debrief, which is incredibly important. And following this, we have admin. So I might go to debrief with a GP and they may say, actually, I don't agree with this little thing. Maybe just add this or request this extra blood, or maybe do this or request this. Then you can go back and have that admin time to do that, followed by a lunch break if you're lucky. Then you go on to the afternoon. Afternoons tend to be longer because, like I say, my shifts are longer. So I start the day with 3 acute same-day emergency appointments. So if somebody's got something that's urgent on the day, some sort of infection or anything, they come in them appointments, followed by a block, and then 10 face-to-face pre-bookable appointments. This is quite a hefty block where it's back-to-back patients. And so it's very important that you stick to your timings. And then at the end of the day, I kind of have 2 slots that I can book into should I need to see anybody from the telephone triage this morning. And then another block, and then I debrief and come back and do my admin. And that's a typical day in the life of one of my practices. Another practice, I would go straight into my appointments and not do the bloods. But then I would have a bigger block in the middle, maybe to do a couple of home visits. Whereas this practice doesn't really expect me to do home visits, because we don't get that many and they prefer the GPs or the registrars to do them.
Wonderful, thank you. And it sounds quite hefty, especially the afternoon. It sounds quite busy, especially if you use those 2 slots in the afternoon. So it means you basically have 12 face-to-face patients in a row, which can be quite busy, can be quite time-consuming as well. Do you tend to finish on time?
That was one of the reasons when I was doing 9 to 5, I often found that I was running over on my times, and I thought the amount of time that I've run over, if I just did 10-hour shifts, I would get all my work done within them 10 hours and then have the sort of the look of having a day off, really. So I tend not to run over time, and if I do, I catch up in the blocks. So every so often I've got a 10-minute block. If I do feel that it's getting too much for me, I do go over to the manager and I just kindly say, look, it is getting a bit much for me, which it has done in the past. And then she'll just sort of chop and change things, so put an extra break in there to catch up, or maybe change one of the face-to-faces to a telephone, to just speed things up a little. So it depends on your practice, and most employers, my employers anyway, were really, really good in terms of that.
Wonderful. And you mentioned home visits as well. It sounds like you've had experience of some practices asking you to do home visits and others not. Is that the case generally in terms of speaking to your colleagues as well? So generally speaking, in your experience, are PAs able to do home visits? Is just more of a discussion between the PA and the practice as to whether they do them or not?
Yes, so PAs do home visits. However, it depends on whether somebody's available to debrief. So as a PA, we should not be working without a GP or a doctor. That can be a doctor in the practice or in the room next door, or it can be somebody available on the phone. So you can only work if there's somebody working with you. So yes, if you were, for example, in the practice and you were seeing your patient and you sent me out on a home visit, I could do that home visit given that you're on the other end of the phone should there be an emergency or should I need you. If you weren't working or you weren't in the practice or you weren't available, we would not be doing them. Having said that, every practice is different. So places that I've worked in the past weren't happy for me to do home visits, but that wasn't just myself, that was also the registrars and the juniors, because of the lone working policy. So it all depends on the policies that you have in place. I've worked in a place where we didn't really have a policy for lone working, and whilst that was being developed, it was halted for us to be doing home visits whilst all that was being put in place. And then following that being put in place, we were then allowed to do it. So it wasn't so much PAs shouldn't be doing them, because we do them, but it was more so the working policy, the lone working policy of this company. We needed to have certain sort of alarms and phone calls and protocols in place in order for this to happen. So yeah. Some people don't like you doing home visits because they have other things for you to be doing that's more valuable with your time. So for example, I didn't do home visits in one of my places because they preferred me to do care home. So, which is kind of the same. I would go out and do my care home ward round, which meant the GPs then split the home visits between themselves during the week. So it was kind of about making it fair for everybody as well.
Yeah, wonderful. Thank you. Lovely. Now I'm going to hand over to Saira, who's going to continue the discussion.
Thanks, Minali. Thank you very much, Simran. That's actually really informative so far as to how what sort of, and it seems very interesting as well. It seems like you see a lot of variety of patients as well. But is there anything that you can't see, or is there any particular patients that you do see? Is there any limitation to that?
So as PAs, it's very dependent on the PA themselves. So for example, if you're a newly qualified PA and you've come straight out of university, you may not be comfortable in seeing certain types of people. So for example, you may not be comfortable with seeing children under the age of 2, children under the age of 5, or end of life patients. However, over time, you tend to build up your confidence. I know PAs that have said, you know, I don't want to see somebody with this condition, or I'm not confident with this, which is totally fine to say that, because it's better to say that I'm not confident in this, but I'll go away and learn it, rather than force yourself to do it. But myself, I see everybody from birth to sort of death. That's just how I've built my confidence up quickly. I sort of thought to myself, if I restrict myself to start with, I'm never going to learn. So I see everybody from sort of birth to sort of death. The only thing I don't do is the 6-week birth check, just because that's something I'm not confident in, but I happily hand that over to the GP and they're more than happy to do that themselves. If there is something that's particularly challenging, I will make that known to the GP. So although I see everybody from birth to sort of death, and obviously we can't verify death either, so if there is somebody that's sort of dying, I will need a GP to come and verify that. However, if there's people with multiple comorbidities, I do make the GP aware and say, look, this is very, very complicated and complex and out of my remit. I would prefer not to see them. And the GPs, more often than not, are very, very happy for that and will say that themselves. And quite often, if I do have something and I want to challenge myself, because you do have days where you get your coughs and your colds back to back, and you sort of think to yourself, I haven't really challenged myself today. I will see somebody that's complex, but I will get the GP straight in with myself to come and sort of have a chat with them as well. So that just means that next time I see somebody that's a bit more complicated or a bit more complex, I have that experience from seeing somebody the previous time. That just means that I've got somebody backing me, I'm doing things by the book, and I've got somebody there just in case I need them. So yeah, and somebody with that experience that obviously we don't have that much depth in, because there's a lot of conditions that PAs can do, but there's also many that PAs don't have as much sort of knowledge in, depth of knowledge. So it's nice to have that GP or that second sort of person behind you to sort of give you advice and guidance on that.
Yeah, absolutely. Okay, thank you. So there isn't any particular list of, okay, you shouldn't see them. There isn't any laws around it. It's just down to the person and what they feel comfortable with. And I think it's important to know your boundaries, like you said, but also ongoing learning as well. So it's that balance, isn't it, to have? But that's great to know that as a whole, if a person is happy, they are able to see most people. So yeah, so that's where you might want to tell us that if there is any limitations with your role.
So as a PA, we can do quite a lot of things. So for example, we can take histories, we can examine patients, we can see undifferentiated patients, we can see long-term and chronic illnesses, we can perform diagnostic and therapeutic procedures. There's PAs that I know in secondary care, for example, that can do chest drains or different types of taps and things, and somebody like myself wouldn't be able to do it because that's in GP we don't do that sort of thing, and that's not what I'm trained in. But if I was to move over to the hospital and to secondary care, I by all means, yes, could ask a consultant or a registrar to teach me and show me how to do that, and I could train myself in that. We can develop and deliver treatment and management plans as well. Of course, we do that with all of our patients, and we can request and interpret diagnostic studies. such as ECGs. So it's important to note that it's things such as ECGs, and we can interpret chest x-rays. Obviously not in the depth that a radiographer probably would, but we can sort of have a look and see if there's any pneumonias or lung punctures and things going on. And we can also refer patients to appropriate services and counsel them. So if you've got a smoker, if you've got somebody who unfortunately is using a lot of drugs or anything like that, we do have the appropriate services that we can refer them to. If you have somebody, for example, who is in need of a crisis team, we can also refer into them, to the mental health team. There's a lot that a PA can do. Having said that, there are limitations, and it's very important as a PA to know your limitations. And I can't stress this enough. As PAs, the majority of PAs know their limitations, and that's why we can work safely. It's important to know that not every PA is the same, and every PA knows what they should and shouldn't be doing. And one of the things that we can't do is prescribe, as a lot of people know. And we also can't request ionizing radiation. So ionizing radiation would be something like a chest x-ray. Now, if I was to get a patient that came in with a cough that was ongoing over 3 to 4 weeks, and it wasn't viral, we tried everything and nothing was making it better, or I suspected it was something else, or if I suspected something sinister and wanted to request a chest x-ray, I would indeed go to my supervising GP or my on-call GP, and I would say, this person requires this, please may you request it on my behalf. And it is on the head of that prescriber to say yes or no, whether they think it's appropriate or not. So yes, you can discuss this with the patient and say, I think that you need this. But ultimately, it is the prescribing GP's decision as to whether they can sign it off or not. It's important to mention that it's about trust. So when you work in a place, you very, very quickly, to start with, you may be a bit hesitant working with the GP, but you very quickly build that trust. And I've got into a position after 3 years of working with certain GPs that they just trust me. So when I say that I need this, because the first couple of times I'll say, you know, according to the guidelines, they need this. They know that I know the guidelines. They know that I keep up to date with the guidelines. So after a while, they'll just say to me, what do you think they need? And I'll tell them the red flags or why I think they need them. And they'll more often than not be requesting them before I've even finished my sentence. So it's all about building that trust with your GP supervisor, or, you know, whoever's debriefing you, and they get to know you as well. Which is why I like to work in maybe only 1 or 2 practices, because you build that relationship with the person that's prescribing on your behalf, which is very important.
So do you think that's again taught, like things like reading ECGs or interpreting them? What about blood results and things? Are you able to request them and interpret them as well?
Yep, so we can use ICE, we can request bloods, we can interpret bloods, we can do letters. So you usually get admin breaks, and them admin breaks are for bloods, for letters, ECGs and things. I will always look at an ECG and then get a doctor to look over it again, just because I'm not very confident in that myself. It's something that I really struggle with. In primary care, something like a chest x-ray, you wouldn't really be expected to interpret that because radiology kind of do it for you. But these are skills that we are taught at university as part of the course, as part of the masters. We're taught how to interpret bloods, we're taught ECGs, we're taught chest x-rays and things. So you are taught these things. These are skills that you have, but whether you utilize them or not, depending on your environment, is kind of up to yourself. But in short, yes, we do. Some people come in the morning and they will file their bloods. But because I work at many practices, if I request and do a blood today and it comes back tomorrow, I won't be there to file it because I'll be somewhere else and I won't be back until the same time next week. So I personally don't file bloods at the majority of my practices because the GPs need to be there in case there's an emergency. But yes, if you had consistency in one practice, you would.
I'm presuming by ionizing radiation, you mean any form of radiology diagnostics, so X-rays and MRIs, CT scans.
Yes.
So, okay, that's good to know. Is there, again, so you mentioned that you work at different sites. So just going back to a little bit, so people can work individually at sites as well on any GP surgery. So you've got experience with other PAs that are working individually in surgeries as well.
Absolutely. No, I was going to say absolutely. So when I was working in Bestwood and Sherwood, I was part of the GP Alliance, the Nottingham City GP Alliance. So this is an organisation that hires loads of PAs, and each PA gets put in a different PCN. So although I was working across multiple practices, I would go somewhere on a Tuesday, and then the next day on a Wednesday, there'd be another PA there. Or some places that I was working had actually hired locum PAs, so they'd have locum PAs there. So it's not that I'm the only PA there, it's just that the PAs aren't there at the same time, if that makes sense. Because I would be at one place one day, and then I would do my care home ward round the next day, in which time another PA, locum PA, would come into that surgery. So it was always about which practice had the need for it, and also speciality. So like I say, my speciality was working in care homes and things, so they would put me in an area that needed that work, that needed the patients from the care home to be seen, that maybe weren't getting that or weren't getting the attention from the GPs, and then they would put maybe a PA that wasn't specializing in that or wasn't used to doing that and was used to doing more mental health in more of a socially deprived area to work with mental health patients. So it's all about utilizing what your strengths are, and not just sort of, oh well, you're a PA so you can go here. It's all about, similar to GPs, if you're a gynae expert, you really want to be in an area or seeing patients that are gynae patients or mental health patients. PAs are similar, you kind of get put in areas that are more socially deprived if that's the kind of area that you're falling into, or if you're more of a RESP, or I know there's a PA in Nottingham that's ENT specialist, and they go in more of the areas that have a lot of ENT patients. So yeah, it varies.
Okay. That's perfect. Okay, that's great to know, really. That and I think that's a really good point to utilize the skills of individual PAs as well. So, so next, I think I'd just like to. You mentioned that you sort of get supervision, or you require a GP on the other side to be there. Can you tell us a little bit more about what support and supervision do PAs or physician associates require?
So, as I previously mentioned, as a PA, you always need to have a debrief, and the debrief must be with a GP or a doctor. So you can't be debriefed by a nurse, you can't be debriefed by a pharmacist or a fellow PA, you can't be debriefed by anybody else but a prescribing GP or doctor. So, and it can't be anybody in training or a junior. Okay, it needs to be somebody that's sort of qualified in that area that's prescribing. And like I mentioned earlier, every PA, it's on you as a PA to know your limitations and to know what you can and can't do. And what I know is that I need to have a debrief. I will not leave the building without a debrief, and that being a thorough debrief as well. It's not just ABCD situation, hemoptysis, UTI, this, that, and the other. It's an in-depth debrief. So one thing that I actually do is when I do my consultations, I write things down because I'm quite forgetful. And when I write things down, I will start or highlight red flags. So if I've got somebody that's come in that's got a red flag for cancer, I will highlight that so that when I go to debrief, I'll say, doctor, I've got this patient and this patient's coming with this, which I think is this, and this is why I want to put them on the cancer pathway or request extra blood. Therefore, I build that confidence and the GP builds that confidence. It helps our working relationship for them to have confidence in knowing that I know what I'm doing, I know my limitations, and I've told them everything. So it builds that trust between us as well. And yet, like I say, it should only be a GP or a doctor that you should be debriefing with, somebody that's prescribing. And more often than not, doctors are very happy to teach. It also depends if you're a teaching practice or not. So a lot of the practices I've worked in are teaching practices. So they're more than happy to take the time out for you or with you and teach you. And if I don't ask for the specific teaching, they will teach me. So, for example, if there's something going on in the surgery that week, if you have a case or a scenario of something, for example, I once had an asthma attack case. The GP then started teaching me about LABAs and SABAs and things like that, which is really, really interesting. And then went and read up on it as well, just so that I was more up to date. I mean, that case was handled really well anyway, but it was just sort of a reminder to be up to date with the sort of latest guidelines, because it is important to remember that medicine's always changing. You cannot get a book for medicine. It's not even the BNF everything is always constantly updating and changing. First line today may not be first line tomorrow. It also depends on your area. So Nottingham, APC guidelines will be different to Derby, will be different to Birmingham, will be different to Sheffield. Every city has their own, depending on what's in that area and what their need is. So yes, sorry, going back to the question, with what kind of support do we require? We just require a debrief. Now, some people debrief once a day, which will be at the end of the day. Debrief twice a day, which will be at the start, sort of at the end of the first clinic and at the end of the second clinic. But that's totally up to you, how you work in your GPs, and what works best for you. Like I say, in terms of teaching, and I think we'll come back to that actually. I think that's another.
Okay. Yeah, no, that's great. So, so in terms of, so you've qualified and you sort of develop your skills as you go along. It also sounds to me that a lot of learning is quite self-learning as well, and there's a lot of it seems like self sort of directed kind of learning and an initiative that should be taken by the physician associate themselves to read up and to approach the GPs, etc. But is there a requirement? Is there like a expectation that every physician associate should do certain training or certain ongoing continuing professional development courses, etc.?
Yes, absolutely. So this doesn't just apply for PAs, this applies for every clinician. But what I will talk about now is sort of PA specific. With PA specific, we need to do something called CPD every year, which is, I think it's clinical professional development, I believe, or continuing.
I think it's continuing professional development, yes.
So this is essentially points, points that you rack up every year. So as a PA, as things stand at the moment, it's important to note that this video podcast is sort of shot mid 2024. So at the end of 2024, things will be changing. So I don't want anyone to take my word for it as to going forward in the future, because things definitely will be changing. But how things stand at the moment, PAs need to be having 50 CPD points a year. Now that is 25 internal credits and 25 external credits. And CPD points come from teaching, from learning, from reading. So for example, every year we have an annual conference, a PA conference at the end of the year, I think around December time, that you can go to, and you can pretty much get 24 to 25 of your external CPD points all in that one day. As PAs, we do get 5 days a year that we are able to take off for CPD or teaching days. And that can count as one of your days. So you can either do little things where I think every 1 hour counts as one CPD point. You can read articles, you can read journals, you can attend juniors training, you can, we also have PLT days, which is where for Nottinghamshire, PCDC put on different teachings and things. Afternoons, 1 day a week, 1 day a month, sorry, the surgery will close down for teaching just in the afternoon for 3 hours, and you can sort of do that and incorporate that into your hours. Or like I say, you can do the annual conference at the end of the year and get all your points in one go. But it is very important that you track it and you get these 50 CPD points a year, and that is 250 over the span of 5 years. Now, if you don't get that, then you jeopardize your career. Essentially, you jeopardize your pin and everything, because the faculty of PAs made you spot checks. They made you spot checks and say, oh, actually, you've only had 20 this year. Why have you not hit this, or why have you not hit that? This is very important to make sure that you're up to date with all the medicine and ongoing, learning and teaching that there is. Like I say, guidelines change all the time. First line today may not be first line tomorrow, and also in different areas. So it's important that you do these trainings to stay up to date with your skills and everything on top. And that's not just sort of teaching. So you can attend junior doctors teaching, you can teach other students, or teach, you could even be teaching registrars or SHOs or doctors something different or new. You can be reading journals, articles, you could be doing your basic life support training and put that down as CPD. You can be attending, like I say, the annual conference and put that down as CPD. There's so many different things that you can do. You can watch educational videos. You can go online and watch. If you're not confident in cardiology, you can read up on some conditions on, the internet. You can read the BNF. It's all sort of considered CPD, but it's very important that you record this. And often there is a CPD diary that we have and an app, and in that app and on that diary you can put reflections. So once you've sort of written this CPD down, you put reflections, and at the end of the year it generates a massive report. So if anybody was to ask you, what have you actually achieved this year, what have you done, you can bring out that report. And it also incorporates your appraisal. So you have to have an appraisal every year as well, and that is also part of that. And so, yeah, that's what we've got to do: CPD, PLT.
So in a way, it's quite similar to what doctors are expected to do as well, which is a continuing professional development. And you mentioned various ways that that can be achieved. So just a little bit more off. So we do have like a platform of portfolio. So do you have that on an app or website? Is that what you're saying, where you record everything?
Yes. So the FPA, the Faculty of Physician Associates, they actually have an app, which makes it a lot easier, because I'm not a person that likes to sit on the computer and just type. Often I'll do a CPD day, and I find it good to go to a CPD day, and on the train home, I like to just sit there and bang it out, because I find that if you don't actually do it, you end up, it piles up and piles up, and you think at the end of the year, I have definitely done it, but I've just not written it, and I forgot it, or I've lost it, or you put it on pieces of paper and they just go AWOL. So because you've got this app, you can just log in straight away, and sometimes, more often than not, when I'm listening to something or I'm watching something, I'll just type out my reflection there and then, so it's just done. It's like a constant log of what you're doing there and then, and it's just so easy to keep track of things. So yeah.
Perfect. And is appraisal something you're expected to have it every year? So you do, is that mandatory?
Yes. So an appraisal is to make sure that you're always staying on top of your learning and you're always trying to better yourself. An appraisal is a time where you can reflect on what you've done. You can ask for something else. So I want to specialize in, my frailty training. Right, I've done this. What's my next step to better myself in this? Or what can I learn that's more actually frailty is not for me anymore. What can I do that's mental health related? Or psychology in elder people. It's your time to ask for more training. It's your time to ask for funding. It's your time to ask for, I bring this value to your surgery. Can you offer me more money? It's essentially, we're looking back at the previous year, what you've done and what you've achieved, and we're looking forward to the next year and what you were going to achieve. It's very important to have one, and actually, as the Physician Associate Ambassador for Nottingham, it's actually something that I'm working with people, PAs across Nottingham, to make sure that everybody is getting these, and these are in place, because I am aware that sometimes things can get very busy, they slip under the radar, and you may not get one for maybe a year and a half, or you may not get one at all. But the way we've been working in Nottingham at the moment, everybody should have had or should be having their annual appraisal sometime in the near future.
Okay, so that's great. Yes, it's very important, like you say, to be appraised and have that personal development plan each year as well. Okay, so just to clarify on that bit, who is the appraiser, or who are the professionals that would appraise a physician associate?
So when it comes to physician associates, it's a little bit difficult because you work across many people. So for example, it's difficult for myself because I worked across 3 practices. Well, I was doing my care home day in 2 practices. So you can't just expect a GP to do it, if that makes sense, because I only work with that GP once a week. So you have your overall employer. Your employer or your line manager will go to each GP and say, what has she done good? What does she need to work on? What do we need to discuss, so that they can build up that overall picture and they can be that sort of assessor and that appraisal person. If you are working at one practice, I suppose, yes, you could have a GP be your appraisal person, but appraiser. But with somebody like myself that works very thinly across multiple places, it's very difficult. So for example, mine was my line manager, who is non-clinical, and he went to all my clinical supervisors, and each of them asked what I was doing, what I need to improve on, what they expect, am I meeting the expectations, have I been doing my CPD? And then he came back to me and had a meeting with me, and in my meeting was a few of those GPs as well. So yeah, it kind of works different for sort of all GPs, depends on your structure.
Okay, perfect. That's great. I think anything else that you'd like to tell us, Simran, before we close the session today?
Not necessarily. All I'd like to say is that PA is a really, really good career, and I think it's something that in the near future is really going to do well. I think at the moment things may be at a bit of a standstill, but we are heading in a good direction. As we get our regulation in December, things will start to go really well for us. So if anybody is considering being a PA, training as a PA, or choosing this as a career path, please feel free to get in touch with me. I also have a TikTok account called PA The Sim Way if anybody wants to get in touch. I do have a lot of students contacting me on that for help and advice, and I have helped a lot, and I have helped quite a few through interview processes to actually get into universities, to get onto the course, and told people much more about it. So if anybody does have any questions, I'm more than happy. Maybe we can put the link on this video or something for you to add. So yeah, for any questions or anything, even if you're not from Nottingham and you're from elsewhere, I'm more than happy to sort of help, because that was the whole reason that I started that TikTok, was to be that presence online where people can come and build that community and a safe space, so we can, you know, talk about things. I can pass on knowledge and help others that were probably me 3 years ago. So yeah, that's all I'd like to say. It's a fantastic career. It's really taking off, and it will take off in the next couple of months as we get regulated and things start to look up. So definitely look into it. It's very worthwhile, and yeah, it's fantastic.
Brilliant. It's really inspiring to listen to, and I think you're doing a great job by helping others as well. So thank you very much for coming today. Minali, did you have any questions before we let?
No questions.
Simran
No, I
go?
just wanted to say it was incredibly insightful, and I think a really useful informative overview of what life is like for a PA working in primary care. So thank you, Simran. And I've never worked with a PA before in primary care, so I really look forward to working with one in the near future. Thank you.
Thank
That's
you.
great. Thank you so much for coming. Thank you.
Thank you.